All right. Good morning, everyone. Good morning. My name is Mrna Little. I am the Executive Director of Cambia Grove, and today we have a great event. We are going to give it a couple of minutes to have everyone get on to our webinar, and then we will get started. So we're just going to give it a couple of minutes here. For those of you joining in the Seattle area, I hope you're enjoying the sunny weather. At least it is where I am. And for those of you across the country, I hope you all are having a good afternoon. We're going to give it about 30 more seconds, and then we're going to dive into today's event. A couple of things to note. Today we are recording the session. Everyone tomorrow should be getting a recap, including the recording of the session. So feel free to sit back and listen and then take notes throughout the recording. All right, let's go ahead and get started. Good morning, everyone, and welcome to today's event, Under the Boughs with Dr. Thomas Lynch, with our host and moderator, Lee Huntsman, who's President Emeritus of the University of Washington. We are thrilled to have both of you two join us today. My name is Mrna Little. I am the Executive Director of Cambia Grove. Cambia Grove is a healthcare innovation hub supporting innovation efforts across the country to create a more person-focused and economically sustainable healthcare system. Couple of programs to note that Cambia Grove recently launched that I would love for folks who are on today's webinar and folks across the country to take a look at. If you have a solution or are seeking solutions to a healthcare problem, we recently launched our Impactful Innovation Exchange, which is an exchange to connect problems and solutions within the healthcare system to hopefully create impact on the triple aim. So feel free to check that out on our website. We also fairly recently launched our membership. We just cracked 200. We're climbing above 200 members. They come from across the healthcare spectrum and really around the world. And so if you're interested in connecting with like-minded innovators, whether you're an entrepreneur or working within the system, feel free to check out our membership. It is free until the pandemic is behind us. And I know we will talk a little bit about what the pandemic potentially looks like in the future and when we can all resume back to normal. But consider joining us as a member if you're interested in connecting with a great group of entrepreneurs, innovators, and like-minded travelers. You can find more information about the membership on the Cambia Grove website as well. A couple of things about today's event. We will be treated to a moderated Q&A session between Lee and Tom around 10:15 or so. I will pop back on screen and start asking questions from the audience. As you have questions, feel free to enter them into the Q&A box that is located on the bottom of your screen. Please ask your questions throughout the conversation. And what I will do is I will try and get to as many of those questions at the end of today's event. So with that, I am going to go ahead and stop sharing my screen and turn the mic over to Lee. Lee, take it away.
Thank you, Mrna. Hello, everyone. Thanks for joining us for this Under the Boughs session. It promises to be interesting and fun with Dr. Lynch. Tom, thank you so much for doing this. Maybe we can start by you just telling us a little bit about yourself, your background, and how you come to be the leader of the famous Fred Hutch Cancer Research Organization.
Lee, thanks. And it's great to be with everyone today, particularly with an organization that is so committed and focused to innovation, because that's really at the heart of what we do at the Fred Hutch. So, Lee, my background is, as you can tell from my tie, I'm a native East Coast person, okay? I've tried to understand that they don't wear ties in the West, even in California, but it's left over from my East Coast roots. Born in Boston, raised outside of New York City, spent my entire career either at Mass General or at Yale until about 5 years ago when I became the Chief Scientific Officer of Bristol Myers Squibb. And then after BMS came here. I've been a practicing physician for about 30 years. I practiced medicine, and I really had a large practice early in my career. I have been involved in translational cancer research, meaning linking patient outcomes with basic biology to come up with new insights into how to treat cancer. I think that's a place where I really got interested in innovation and led to me eventually joining a company like BMS because of it. And then now I'm delighted to be back at the helm of the Hutch. I've always felt that my place was in academic medicine, particularly academic cancer medicine. And there really are very few places in the world like the Fred Hutch. It's a remarkable facility with incredible scientists. And being in Seattle and being in Washington State has been, I think, fantastic. Despite the pandemic, it's been fantastic.
Well, tell us some more about this remarkable place called the Hutch. A lot of us know bits about it, but it's larger and more complicated, I believe, than a lot of people understand. So give us kind of an overview of the Hutch.
Well, let's give you a couple things. So when you drive on Route 5, on Interstate 5, you can look down and you see the Fred Hutch campus. And on the Fred Hutch campus, there are many, more than 1 million square feet of laboratory space, which is the Fred Hutch Cancer Research Center. And then you also have the Seattle Cancer Care Alliance, which is on our campus as well. And I'll describe those two things. So in the Fred Hutch itself, we have 5 important divisions, and we have about 3,500 people who work there. Of the 3,500 people, 250 are independent faculty members, okay? And we work on cancer and viral diseases. Now, we worked on viral diseases even before COVID. So viruses have been a big part of the Hutch even before COVID happened. But it did position us well so that when COVID hit, we were ready to be able to do work in virology as well. And if you look at our 5 divisions, we have a clinical research division focused on cancer. We have a fundamental biology, a basic science division, which is really working on fundamental biology across a number of important questions, including some things that aren't even cancer or virology. We have a public health division. We have a division that focuses on viruses, so virology and infectious disease, and then we have a group that focuses on human biology. If I had to say, what are the 4 key priorities of the Hutch right now? I'd give you these 4. First, a great focus on precision medicine and precision oncology. We're at the time now where we're able to look at genes that are important in driving cancer and linking those genetic abnormalities to patient treatments, big part of what goes on at the Hutch. Second, immune therapies. The Hutch is the home of bone marrow transplant. Many of you may know the Hutch as a center for where people go with leukemia and lymphoma, children and adults, to have bone marrow transplant. And bone marrow transplant was one of the first demonstrations that you could do effective immune therapy for patients. So that happens at the Hutch as well. And we have a big group working on cellular and immunotherapies. Third is this intersection of tech, big data, and cancer science. We're in Seattle. We have more AI people, more people working on cloud architecture, more people working on data integration than any place else in the world. This is a place where it makes great sense to marry these 2 passions. And then fourth would be viruses and infectious diseases. And the link that viruses have to cancer and other diseases are incredibly important. So I guess the last question I'll ask is, why would the Hutch be involved in viruses? And the reason is because it started off when the Hutch was at Bone Marrow Transplant Institute. Many of the patients were getting viral disease and were dying from viruses. And so understanding viruses became really important to the success of bone marrow transplant. Next, it was understood that about a quarter of all human cancer around the world can be tied to viral disease. So it makes great sense that we've been involved with viruses. And the last clarification for you, Lee, is the SCCA. So people might say, well, what is the SCCA? The SCCA is the Seattle Cancer Care Alliance. 3 great institutions, Seattle Children's Hospital, University of Washington, and the Fred Hutch, came together about 23 years ago and formed the Seattle Cancer Care Alliance, which is where our clinical care happens. So patients are taken care of there, and a lot of clinical and translational research happens at the Seattle Cancer Care Alliance. So that's where patients go, and the Fred Hutch is where the basic research is. And then, I think, you know this very well from being the president of the University of Washington, the dynamic interchange between what happens at the Hutch and what happens at UW and what happens at the Allen Institute and what happens at Children's. It's really a remarkable ecosystem to be in Seattle at this point.
Well, I want to come back later and talk a little bit more about your perceptions of our ecosystem and where it might go. But let's expand a bit on your major themes there, which you articulated so nicely. Tell us a little bit more about, we throw the word precision around, and what does that really mean? And what directions do you see here in these areas of science and the translation of that science into clinical impact?
So Lee, I'll give you a great example. When I started my career, as a lung cancer doctor, somebody would come in with advanced lung cancer and we would give them quote unquote chemotherapy that killed cancer cells randomly. And we would find that about 15% of patients had major benefit from chemotherapy in that setting. Not cure, but benefit from chemotherapy in that setting. What precision medicine is, a patient now comes in with lung cancer, beats of their tumors taken out and sent for genetic sequencing. And we would sequence that patient's tumor, the genes in that patient's cancer, and determine which genes were driving the cancer. And right now in lung cancer, we can figure out what the driver mutation is in about 65% of cases. And we have drugs, good drugs for about 30% of those cases, and okay drugs for another 30% of those cases. But precision oncology is the idea that you're not going to treat everybody with chemotherapy. You're going to treat some people with drugs for an EGFR mutation. You're going to treat some people with drugs for an ALK translocation. Other people with drugs for a MET amplification, depending upon what you find when you look inside the tumor cell. And we're finding it's not just lung cancer. It's that way in colon cancer and breast cancer, number of different tumors. This idea of precision oncology has been probably one of the biggest developments. Now, I know, Lee, your group, Cambria Grow, is very interested in innovation. And I think this is going to continue to be an area of great innovation, particularly at this interface between the immune system and precision oncology.
Your mentioning of the immune system reminds me of a couple of observations. Some people have said that one of the reasons, if you're trying to commercialize in cancer and related issues, you'd like to be in Seattle, is because there's so much academic strength in immune science here. But it also reminds me of a comment by one of your predecessors, Lee Hartwell, years ago, said, we're all focused on cancer therapies, but the clinical evidence suggests that a huge benefit can be gained by early diagnosis, because we're much better at treating early cancer than we are late stage cancer. And he was advocating for a major push toward better diagnosis. And it seems like we're in this discovery phase of understanding the complexity of the immune system, bringing together new technologies and big data that you talked about. We're talking about circulating tumor cells. So tell us some more about this intersection between immune science, technologies related to immunology, and the potential for clinical impact.
Yeah, so let me just say one thing on the first part you mentioned, which is this concept of early detection. And I think Lee Hartwell was absolutely correct about that. And I think we're now starting to see some of the promise of that faith that he had in early detection making a difference. So, it used to be early detection involved scans, and they still are important. If you have if you're a woman, you should be undergo mammography to scan for early breast tumors. If you're a man or woman, you should undergo colonoscopy or some other test to determine early signs of colorectal cancer. Many women undergo testing for cervical cancer with pap smears and other types of screening. So early detection is proven to be important in those settings. And I just want to make one comment. The reason that I paused there for a second, I didn't mean to suggest that there aren't men who get breast cancer, because there are, and there are men who get cervical cancer as well, understanding that our definitions of gender and sex are different than they were 20 years ago. But the point being, screening makes good sense. Now, in addition to the kind of traditional screening we now have molecular screening. And I think that's something that I think Lee Hartwell really imagined and thought about. What could we do with it with molecular screening? And there are companies and laboratories now that are taking samples of blood from patients and looking for early genetic changes that could possibly indicate early signs of cancer in the blood. Very much in its infancy, but it's a good example, Lee, of this connection between precision oncology and early detection. And I do believe that Lee is correct. I think one of the reasons we're going to improve outcome from cancer is greater influence on early detection. Great example of this is pancreas cancer. One of the reasons we don't cure pancreas cancer is because by the time we diagnose pancreas cancer, it's already out of the barn, and we don't have that ability to be able to cure patients with pancreas cancer in that setting. So very important to know that we need to keep looking for new ways to detect cancers early. And whether you're going to bring an immune treatment or a molecular precision treatment to the table, I think either of those can be dependent upon stage of diagnosis. But it would be even better to be able to do what we do often in breast cancer, which is you find an early breast cancer, you're able to surgically remove it, and the patient does really well. And some of the patients don't even need any other treatment afterwards. And again, one of the promises of early detection. So I really do believe that's a big focus of what happens here at the Hutch as well.
Okay, but you mentioned this, also the intersection of technology and big data with cancer science. And what's big data got to do with it?
So if you look at, that's a great question. If you look at the way laboratory data is done, again, we go back to 30 years ago or 40 years ago, when laboratories would generate data, they would generate relatively small amounts of data for an experiment. You might look at an enzyme reaction, and the enzyme reaction you might quantify by how intense it was. Or you might measure tumors in an animal model to try to see if the tumor got bigger or smaller. Now with genomics, and with proteomics and with metabolomics and with the understanding the microbiome, you are generating terabytes of data with every experiment you do. So just the data storage issues of what we do in understanding cancer have increased dramatically. So cancer needs and innovation needs data scientists. And again, this is a great place to be because there's so many data scientists at the Hutch in Seattle who are working on exactly these problems. And so a scientific experiment now, particularly in our human biology division, for example, is generating unbelievable amounts of data. And then there are some scientists now, some cancer biologists who are really your data scientists and who spend the majority of their effort interrogating large databases, looking for the nuggets of information that are already there in these data sets that we want to try to extract and understand. So I think there's tremendous potential for this. I also think from the clinical standpoint, as a clinical practicing doc, I think the potential for data science to influence how we practice medicine and how we deliver clinical care is going to become really important.
Okay, so let's follow up on that in terms of one of the things you mentioned earlier was the Hutch's role in translation, which is a general word that we all use to talk about getting the science to zones of impact, either clinical impact or commercial impact. And yet you also mentioned that you've felt a strong desire to return to your academic roots and be part of an institution like the Hutch. And you know, I'm old enough to remember the day when there was an open question about whether academics should be involved in translation, particularly to commercial applications, and how on earth would they ever safeguard their ethics and conflict of interest problems. And yet it's a whole new day. And the Hutch is one of the most active translational organizations that I know of. Supremely active on both the clinical and commercial fronts. So tell us a little bit about your observations. How does that happen? What nurtures it? What keeps it in bounds?
So a couple things is that you want to, you want to take an idea, and you want an idea to go from an idea to a product, to a drug that can treat patients. How do you get from an idea to a product? And this is something that nowadays I think involves a very complex ecosystem. Ideas in general start at places like the Hutch and the University of Washington and MD Anderson Cancer Center and Mass General and Yale and Hopkins. The academic medical centers around the country are where ideas start. For an idea to turn into a product, a lot has to happen. And you come up with an idea, you might do some principle to be able to prove proof of concept enabling studies at an institution, but eventually you'd like to be able to commercialize this and turn it over to the industrial side. Now, the industrial side in the old days was really just big pharma, but over the past 20 years, it's become biotech and big pharma. In the past 5 to 7 years, there have been a proliferation of venture capital-based biotechs that are making a huge difference in how we commercialize and develop ideas. And so you take an idea from a place like the Hutch, you form a company around that, a company like Juno, which was founded around some of the technology from the Hutch. And that then allows the company to do more focused, commercially driven experiments that are better done in either biotech or pharma than they are necessarily at the Hutch. I want my scientists at the Hutch focusing on ideas and idea generation. I don't want them trying to engineer whether a treatment should be designed in one type of buffer or another for giving to patients. So biotech is really good at getting the ideas off the ground. And then ultimately, if you want something to be commercialized and spread throughout the world, that's where big pharma can be very helpful as well. Now, sometimes a really good biotech can turn into a big biotech and commercialize things, but often there's that pass off between biotech and big pharma to make that happen. So the other question is, that's sort of the ecosystem. The other question you might ask is, how do you protect conflict of interest? And the Hutch has been very aggressive in developing biotech companies. A number of biotechs have spun off from the Hutch, Juno being a great example. Adaptive came from science-based at the Hutch, Lyle from science-based at the Hutch, and we have more than 100 examples of that. And I think it's really important that we have firewalls between activity that happens in these corporations and the work that happens at the Hutch. And so one of the things I think we've understood is the importance of separating the work into very distinct realms. And we don't have, for example, physicians involved in patient care or patient studies who have ownership interests or commercial interest in the companies themselves. And so that's an important principle. And that's now accepted nationally. That's not just a Hutch thing. That's a national thing in terms of looking at conflict of interest and managing conflict of interest across that. But there's no doubt that the ability to quickly commercialize from the idea stage at a university or an institute like the Hutch to a biotech is one of the things that's fueled the current optimism that I have for where we can get to in cancer. And look what's happened in virology. Look what's happened in COVID. I mean, I know that we're all upset that we don't have a vaccine yet, but the fact that we may be getting data on a novel mRNA vaccine approach or 2 novel mRNA vaccine approaches in the next couple of weeks is stunning. We didn't even know about the virus until January of this year. So the system is more nimble than I think people appreciate. And I think one of the reasons for that is because of the role that biotechs play in the middle. Remember, big pharma is huge, okay? And the ability to, they always talk about turning an aircraft carrier around. The ability to turn around an aircraft carrier is not easy. And so for big pharma to move fast is harder. And for the Hutch to develop an idea on its own, we don't have the resources to do that. We don't have the economics to do that. That sweet spot played by biotech, I think, and for the people on this call, I bet you many of the people on this call are either investors in biotech or people who do biotech. That niche, that world is really important to both what happens at the Hutch and what happens in pharma and ultimately for patients.
Great. And I want to follow up a little bit about what the pandemic reveals about all these players and how they work together. But let's pause a minute on that concept of an ecosystem. So you're relatively new to Seattle, but a veteran of the whole life sciences sector. What's your impression of the pluses and minuses of the ecosystem we have here and the directions that system might take?
So I'd say the pluses of the system are that Seattle's a very dynamic place, okay? Meaning, and people share pretty readily here, and it's sized appropriately right now, meaning you have enough critical mass in biotech and in academia to be successful, okay? If you're asking what are the downsides to Seattle, is you're not sized as large as South San Francisco, Palo Alto area or Cambridge. So Cambridge, Mass is by far the biggest focus of biotech. South San Francisco, that area would be the second. And then I think Seattle, San Diego would be the third areas where biotech exists in an ecosystem. I'd say if you look at all of these places, why is Cambridge such a great place for biotech? The answer is MIT, okay? And then a little bit Harvard and Dana-Farber, Mass General, those other places, but MIT has had a huge role in creating a culture of entrepreneurship and innovation. Same thing I think you can say with what's happening in the Bay Area. Stanford and UCSF have had an enormous influence. And then here, it's the Hutch, it's the University of Washington. That dynamic relationship, it's not an accident that companies start in places like this, where you've got a lot of people thinking about problems and a lot of people coming up with potential answers. It's also not an accident that in all three of those places, you've had a relative mix of tech with biotech. Now in Boston, tech is dramatically less than it was. Okay, not zero, but it's less than it was. Tech is still huge in Silicon Valley, obviously, and it's still big here in Seattle, obviously. So it's interesting that those two kinds of ecosystems have existed in all three of the cities.
It is indeed. And does that how does that relate to your sense of where things are going, what the future is?
So I think we have a place where people where again the size is right for collaboration and for connection, and for example, and we have the ingredients in place so that, for example, if one of my scientists says to me, Tom, I got this great idea, I want to form a startup company, we have people at the Hutch who help get that going, get the scientists connected with the right venture folks. And Seattle has space. Companies like Alexandria Real Estate, companies like Vulcan have created laboratory spaces and incubator spaces where companies can get off the ground. And so that's an important part of what you need in a system like this too. And again, go to San Francisco, go to Cambridge, go to New York City now, you find a lot of incubator space where a biotech who literally only has 3 employees can step in and get something going. And I think that's a big part of our culture here. And I think if you just go up and down Eastlake and you see what's happening on Fairview Avenue, and then you go into Eastlake, there's tons of little companies you see that don't even have big titles yet. but are getting going, and I think that's really exciting.
So let's now switch to the pandemic and talk. First of all, what's your assessment of the state of things there, both in terms of diagnostics and therapeutics? And then I want to come back and reflect on what this intense season may mean for us as a biotech ecosystem. But give us your perception of the character of this pandemic and the various responses to it.
So I'd say a couple of things. I think that Seattle has played an incredibly important role in COVID, in understanding COVID and helping to develop answers for COVID. So the work of Trevor Bedford and the Seattle flu study very early in the process. And this is a Seattle flu study, which has turned into the COVID network, was put together by the Brotman-Beatty Institute, and the Brotman-Beatty Institute being a really great example of the University of Washington, the Hutch, and Seattle Children's, all working together under the leadership of Jay Shinduri. And then Trevor has been running the molecular genomics and the genomic epidemiology part of that. And Trevor was responsible for sequencing the virus very early in the outbreak. And so getting those sequences out to biotech companies early allowed them to begin to work on vaccines. And so that was really, really important, that we were able to get the sequence of the virus down and understand the epidemiology of the outbreak. That's number one. I think the second key thing to point out is that we're seeing the evolution of a viral epidemic that we don't yet have a way of controlling with pharmacologic means yet. So we don't have a vaccine yet. We have treatment, which is certainly better than it was in January, February, but it's not widely available yet, nor is it evidence that it has made, that it has eradicated the disease, put it that way. I'm sure there are many patients who benefited, but it hasn't eradicated the disease. So what you're seeing is that we now, if you think about the former commissioner of the FDA, Scott Gottlieb, what he has said in the past 24 hours is he believes that the next week or two is a critical time for us because of the potential explosion in the number of cases. And we're clearly seeing nationally the number of cases go up. I can't stress enough that the importance of what we're doing in Washington State in terms of masking, in terms of social distancing, in terms of avoiding interactions with large groups of people who are not masked, has made a difference and allowed us to keep our numbers down. However, our numbers, even in Washington, have crept up a little bit. Now that's the whole state. It's a different story depending upon where you are in the state in terms of how those numbers have gone up. But we're not out of this yet, is the key thing. And the difficult thing is, I want to be out of this. Lee, you want to be out of this. We're done with this as people, okay? We all have COVID fatigue, okay? And so the question is, how do we maintain the discipline to stay masked and to not go to the kinds of things we want to go to, the gatherings we want to have? I think the big crisis that I'm having in my family is, what do we do for Thanksgiving? Dr. Collins, Francis Collins, the person who is a spectacular scientist, who was responsible for understanding the human genome, and he runs the NIH. He said on the news last night that for the first time in 27 years, he's not gathering his family for Thanksgiving because he does not believe it's responsible. So the big worry we have now is that the transmission events will be when we get our families together for Thanksgiving. And that'll be a big issue in November as that happens. So we're not out of it yet from an epidemiology standpoint. We need to continue strict distancing, masking, and continuing with what the state has done so far. So I think we've done as well as we can, but we can do a little better if we get more commitment even to this. I think the question is, we'll begin to really get out of it when we have an effective vaccine. But as Larry Corey, who's at the Hutch, who runs a big part of the COVID prevention network, which is part of Operation Warp Speed, as Larry points out, we need more than one vaccine. So we're probably talking about 1 or 2 or 3 vaccines that we're going to need to see initially before we're going to begin to see some turnaround in the population. And now remember, we expect to get some data on vaccines by the end of the year, but by the time you can get those vaccines to patients, we're probably looking at some time in 21. Maybe the highest risk people can get vaccine in the winter, spring, but before a standard risk person gets vaccine, we're probably looking at the middle of 21 at that point. And that's assuming, and we don't know this, that's assuming that the vaccines are shown to be efficacious and safe. And we just don't have that data yet. And so that's what the trials are going to hopefully give us some sense of. Now, until we have vaccines, we have to rely on treatments. And that's where drugs like remdesivir and drugs like the monoclonal antibodies and dexamethasone, all 3 of which President Trump had for his bout of COVID, those drugs we're going to need to learn how to use better. And one of the things we've done at the Fred Hutch is we established an outpatient COVID center to study these drugs in patients with COVID-19. And we're studying these as outpatients, which is really important because you want to look at it in earlier stage disease. So lots happening in this area, incredibly dynamic environment. And I just would urge people to stay the course and continue to find deep within them the reservoir of will to wear masks and avoid social connection.
Yeah, but Tom, let's go just a little bit deeper here, because you're absolutely right. We all are having COVID fatigue, and yet most of us are congenital optimists. And so we're sitting around hoping that the scientists and physicians are going to save us here. But if you back up with a perspective of drug development and the remarkable time, expense, and low success rate of phase 3 trials, there's a sort of an in-your-face reality that says, well, don't make any assumptions about rapid success with vaccines. But on the other hand, the science is different. You mentioned mRNA vaccines, and those are new approaches, I gather. And what is your sense of what's going to work here?
So I think in terms of vaccines, we don't know which vaccines are going to work. Okay, I mean, okay. I think that you've got some standard protein-based vaccines, and then you've got these mRNA vaccines that are going to be very exciting to see how they work. And the mRNA vaccines basically program your cells to make copies of the protein that your immune system can then design a molecular response around. Very innovative idea. But remember, there's no examples of that yet in human drugs. So this will be a whole brand new idea, as opposed to using the protein with an adjuvant in a more traditional vaccine-like approach. And so I think, Lee, that's one of the reasons why there's some uncertainty as to when, i.e., will the vaccines work and when will they work? And Pfizer has mentioned publicly, and Mrna has mentioned that they expect some data by the end of the year. But remember, that's the very earliest data. And the very earliest data is not necessarily the data that you and I are going to be able to make a decision, or not you and I, that the FDA is going to be able to make a decision on whether to approve this vaccine for general use. And I think that's a big question as we go forward. I also think this issue of vaccine denial is going to be really important, because we're going to need data to be able to convince, I mean, some people you'll never convince about vaccines, but to be able to convince reasonable people that vaccines make sense, you got to be able to have enough safety data to say, hey, we treated this many patients, these are the safety issues, these are the efficacy issues, because I think people want to see that.
Okay, well, I'm sure there's a lot of questions queuing up there in Mara's inbox, but let's just finish up this section, Tom, by reflecting on all that you've told us about the Hutch and the state of the science, but now in the context of this pandemic. Any sense of how this Greater Seattle ecosystem is going to go forward, what the potential is, what the grounds for optimism might be as we take this energy, this science, this pressure, if you will, to go into the future? What do you see in front of us?
I'd say the the reason for optimism here has been that we've done better than national averages in terms of control of the virus in our community. I think we can do better still, but we have a good culture of that in Seattle and in Washington State. And I do believe that these treatments are going to begin to make a difference. I think we probably are going to have to get used to 2021 is still going to be a year of COVID, meaning that we're not going to get through COVID in 2021 completely. But the hope is once we get through the winter, there'll be a vaccine that will start to get used, and perhaps more of our high-risk people will be able to be benefited at that point. And as the year goes on, some of our standard risk people will be able to get vaccinated at that point. So I do have hope we will emerge from this on the other side. And then the other question is, what have we learned from this process? And I think, we've learned a lot about our work, how we work, okay? Meaning that, the fact that you and I are having a teleconference now instead of this being a live meeting in a meeting room is an example of how we've been able to accommodate some of the changes. And I think that some of where we work will be different when we come back, when COVID's finally finished. I think that remote work will be a bigger part of how we work together, whether it's a tech company or it's a cancer research center. I think if you're a hospital, even in a hospital where you need to see a doctor or a nurse, I think even in the hospital setting, we're going to find that virtual visits can accomplish a lot of what we're trying to do. So I think there will be changes to our society as a result of COVID, some of which might be positive, some of which might allow families more flexibility in how they raise families and how they work and accommodate their families. So I'm not totally pessimistic that we might not develop some advantages after we get through this.
Okay, terrific perspective. Thank you so much, Tom. Mrna, how are we doing on questions?
We have got a lot of questions, some great ones coming in, and we have about half an hour or so to get through as many as possible. And there are some ones that can take us in a number of different routes. If you have questions, please do type them into the Q&A box on the bottom of your screen. And I am going to start with Alicia. Alicia, it is great to see you come through the question box. I hope you're doing well. We miss you and so many people who we used to see at the Grove. Alicia asks, do you think that the changes because of the pandemic, collaboration across the country as well as the world has become more open? Or is it more about whom is bringing the right vaccine and a competition? So it's that notion of collaboration, competition. Lee, I remember Chris Rivera coining the term, or someone in the community coining the term co-opetition from the Seattle-based ecosystem. But Dr. Lynch, what are your thoughts around the balance between collaboration and competition?
I'd say a couple things. One is I'm someone who very much believes that the move to a global world is inevitable. Okay, it's clearly delayed by what's happening acutely, meaning we're not traveling, we're not going to other places. But the fact that our world has become more interdependent is something that can't really be stopped or denied. That kind of innovation is going to happen. And what happens in China and Russia and France and Brazil and India impacts what happens in Seattle, New York, and Houston. And so I think that doesn't mean we're not going to have national identity. It doesn't mean that America won't still mean something as a country. It will always mean a tremendous amount as a country. But increasingly, we're going to become more involved. For example, AstraZeneca is a British company, and we're working with them on a vaccine. There are Chinese vaccines that look promising in COVID, and there's work from India that also looks promising. And I think you'll see eventually, whether it's COVID or anything else, that this work on global innovation will continue. And I think that the markets have voted with that. I think that the large companies around the world are all global companies in the way they think about this. And I think that ultimately we'll be a better society if we're able to do this. Now, you need to do this in a way that doesn't lead to lack of workers' rights and lack of working conditions that people can have. I'm not implying that everything about globalism is great. There are problems with some parts of globalism, but I do think, particularly in science and innovation, you're going to see this happening. I think that one of the good things about COVID has been you've had a number of pharma companies that have collaborated on putting together some of their efforts in creating a vaccine. So I think that's a really positive development. I think we all think that collaboration is a good thing as it moves forward. And I think as a place, I think that Seattle is a very collaborative environment.
Great. Alicia also talks about, Alicia, you do have so many questions. I am going to touch on a very direct question. Dr. Lynch, how confident are you about the vaccine or a vaccine?
So again, I'm a cancer doctor. So I am not a viral expert, but my viral experts at the Fred Hutch are confident that one of the vaccines or one or more of the vaccines will work. And so I take my cues from my viral experts at the Hutch, and they do believe that one or more of these vaccines are very likely to work based on what they've seen in the phase 1 and phase 2 data. Now, that's not the same thing, Maura, as saying that we know that these are definitely safe. Okay, we need to see safety data. We need to see the degree of efficacy data. All of that needs to be looked at. But the early data suggests that you can stimulate a specific immune reaction. And what we need to show is that the specific immune reaction matters, that it can either prevent infection or prevent serious illness. Remember, both of those are important goals. Preventing serious illness is incredibly important. Preventing infection is even better if you could do that. But whether we can, if you think about the flu vaccine, some could argue the biggest benefit of the flu vaccine is preventing serious illness more than it's necessarily preventing infection with influenza. And different vaccines have different abilities, whereas measles vaccine prevents you from getting measles. Yeah. We don't know yet about the COVID vaccines.
One of the questions on here, and Matt Weeks, I see your question as well. If we didn't touch the structure of your question, please feel free to type it back in. But Matt had a question around communities collaborating as well. The next question is around the role of, you called it tech versus like biotech or innovation. And at the early stages of the pandemic, we saw a lot of tech thinkers who were entering into the healthcare system. And it was really tough for them to collaborate. They might have a solution, but the healthcare system isn't ready to really bring it in. Can you talk a little bit about, and a lot of these elements, the NFL is using some of these things. I know other, major league sports are using some of these things around tracking and tracing. Can you talk a little bit about the role of tech in the potential prevention of transmission and even moving forward in the pandemic?
So I'd say a couple things. One is that you just talked about, I think one of the big themes of what we're going to see in the next decade is this intersection between technology and healthcare, okay? The idea of wearables, the idea of what the new Apple Watch and the Fitbit and what other Whoop, I think it's called Whoop, is this new device that the athletes wear. And so wearables are going to have a big impact on how we look at health, okay? So that's definitely a trend that's happening. And that kind of trend is going to make a big difference, okay? So for example, if you have congestive heart failure, you can, from your Apple Watch, transmit important parameters about how your heart's functioning to your cardiologist. and your cardiologist is going to be able to make changes to your medication based on some of the things they're finding out. So tech is going to continue to do that. I think another place tech is going to be important is in the interaction and how patient medical records are handled. So for example, as a doctor, when I'm seeing a patient, right now you see the patient and then you spend 10 or 15 minutes entering into the computer record. I believe in the future, you'll have an open computer in the room with you when you see a patient, and the computer will automatically record the interaction with the patient and structure that into a medical record for you as the physician or the nurse practitioner. And then all you have to do is click agree and send it. And there'll be a plan based with evidence-based enabled decision-making cues that will help you to able to practice medicine. So I think those kind of innovations will help. And then finally, in terms of tracking and tracing, yes, eventually as testing gets better, and I think, Lee, you asked me about this and I kind of dodged the question on testing, but I shouldn't have. We need better point of care testing for this. We need this to be like the rapid strep test they can do, or like a pregnancy test, which has been a great benefit for people. You need to be able to do something that you can quickly test to figure out whether you've been, whether you're infected. And then the tracking tracing, I think, has abilities as well in terms of being able to find out all the people you've been in contact with or whether someone's been near you. Now, we haven't activated those things. There's a lot of concern about data privacy, and I think those kinds of things need to be worked out. And I'm not an expert in data privacy, but I think many people care a lot about the privacy of their data. And so I think there are some issues that need to be worked out, but I do think there are some solutions, as you point out, in tracking and tracing that are based in technology. And it's just a question of sort of unleashing those and getting those out to people.
Great. All right, we are going to somewhat, I mean, we can talk about it in context of COVID, but there are some questions in here around the other large issue that our country is grappling with around systemic racism and healthcare and health equity, and how does the healthcare system, as well as the innovations that are coming at the healthcare systems, how do we look to level longstanding health disparities? One of the things I learned from one of your colleagues, Dr. Fred Applebaum, during the Cancer Moonshot years ago was, I think he said it was 3/4 of cancers can be prevented either through better diet, exercise. A lot of it has to do with social determinants of health, potentially in communities, throughout communities across Washington. If you have better diet, if you have better exercise, there's opportunities to potentially, reduce cancer in different communities. The question specifically, though, and I'll ask this, is the pandemic has shown a bright spotlight on long-standing health disparities. How will Fred Hutch work to level health inequities? And are there opportunities for Fred Hutch to take a leadership role in that space?
And more, that's a fantastic question. So I'd say a couple things. The first is that we recognize, and it's not just the Fred Hutch, this is American society recognizes that the burden of COVID has fallen hardest on communities of color and socioeconomically disadvantaged groups that don't have the luxury of doing a Zoom call from home like many of the people on this call are doing. Okay, and it's very easy to socially distance and still work and be productive when you can do when you have a job that allows you to do a Zoom call. If you're working in a job where you don't have that luxury, there's no doubt that the burden of the pandemic has been higher in that group. And I think there's several things. There's the response of the Hutch to structural racism. And then there's how do we look at that with this pandemic? So with I'll do the pandemic part first. with the pandemic, we're working really hard to make sure that our vaccine trials that are coordinated through the Fred Hutch include recruitment of people of color, okay? And that's really, really important that we have diverse enrollment in these trials. And the reason for that is that ultimately the vaccine won't work if everyone doesn't get the vaccines down the road. You want as many people to get them as possible. And if you don't have sufficient numbers of Black, Indigenous, people of color who are participating in the trials, you're going to have a hard time convincing communities that these potential treatments can be effective in their communities. And so we've been spending a tremendous amount of effort doing this. And one of the reasons we think we've been somewhat successful is we had this longstanding HIV prevention network and many community health educators who've been in the community who are able to use those connections and contacts in the communities of color to be able to pivot to recruiting into trials of vaccines. So I think that that's an example of how we're working to address an important health inequity there. And the second question is, what is the Fred Hutch doing about it as an institute? I think the most important issue is the recognition of structural racism as a reality and as a critical problem that needs to be addressed. And I think that's a big thing that we've done at the Fred Hutch. The second is, what are the things we can do at the Fred Hutch as part of that? Because the answer to this will be multifactorial. There's not one answer to how you approach systemic racism. And I had this moment where this became really clear to me during anti-racist training that I went through. And you see the daunting impact of structural racism in our society across so many domains. And I threw my hands up and I said, my gosh, how are we going to approach all of these different problems? And the person said, but Tom, you're a cancer doctor. You've got the complexity of trying to treat cancer. It's the same idea, meaning when you've got a problem that's this enormous and this involved in so many aspects of society, it's going to take multiple different approaches to begin to address. And so what we're doing at the Hutch is working to impact the education of younger students of color to encourage people to consider careers in STEM and to provide avenues for making 7th and 8th grade classes better for science teachers. Second is making sure that we recruit people of color to the Hutch for jobs, making sure that we choose vendors that are Black-owned businesses when possible to be able to support our community. Working to recruit faculty members of color so that there are role models and people who can be reflective of the populations that we serve in our society. And it's not going to be something that's going to be fixed in 6 months, but the commitment to it, I think, is going to last. I think that the one thing that we'll take home from this year is an appreciation that structural racism is real and that it is a reality to the experience of so many Americans, and that we have an obligation morally to begin to fix this. And again, the fix may take a while, but the commitment to the fix is there.
Mm-hmm. All right. Next up, there are so many great questions here. I'm going to go back to Matt's question because I didn't quite cover it in my question that I posed from Alicia. So I'm going to read word for word what Matt talks about here. So his question is talking about actual teams working, companies, investigators, and startups, the tech, etc. He says, we can't sit in rooms as we did before COVID. We are pretty good at the downstream project collaboration, but we have no real models for the deep thinking and close collaboration or collaboration work like we saw in incubators, academic labs, and mixing with industry people. So what is working in this new world?
So Matt's pointed out a great, I think a great problem. Okay, and I've experienced this as a new leader. I've been at the Hutch. I started, my first day was February 1st. I had a month where I got to actually meet people in real time. And the rest of my time at the Hutch has been on calls like this, has been on Zoom calls with my teams at the Hutch. So I really do appreciate how you can do some things by Zoom and how Zoom is going to make certain things easier. Okay. For example, we have committees that review research proposals and need to make sure that they're ethical and safe and effective. Well, those committee meetings are fantastic by Zoom because you've got people all over the place that can collaborate. Zoom will be great for that. But what Matt points out, which I think is a really important thing, is you get, some of the best ideas come from people sitting in a room with a whiteboard together, or people having a couple of beers together after work and thinking about, hey, what if we did this or that to make this better? And those kind of collaborations are what I worry about not happening now, because those aren't going to happen on Zoom. I don't care how many Zoom happy hours you plan or social gatherings on Zoom. They're not social gatherings. Okay, they just don't have that same energy to them. And so I think that you'll still have a need when we come back from this for personal interaction, and for getting people in small groups to get together and brainstorm. And I think brainstorming is one of the things that becomes harder. You can certainly try it on Zoom calls, and small Zoom calls with 3 or 4 people can be effective, but it's hard. And I think it's particularly hard in the realm of creativity. Okay, it's kind of easy on the business side of things and the executive side of things, but in the creative parts, whether you're talking about the performing arts or scientists, places where creativity is important, that I think is really tough to do on a Zoom environment. And if Matt has any great ideas, I'd love to hear them, in terms of how to make that work.
Oh, yeah, I would love to hear them as well, for us at the Cambia Grove team. Lee, do you have anything to add about that creative discovery process?
No, not really. I'm in the same space Tom is. There's an element of the spontaneity and the follow-up to sparks that it seems to be difficult over Zoom because we tend to be more structured. But it's interesting. This video conferencing is actually an improvement in some ways. It's significantly better for me than a phone call. And of course, I noticed that especially with my grandchildren, right? I have longer and better calls, but the I don't know, because the creative environment has switched over the years. You used to have lunch together, and now it's you send emails to the people in the cubicle next door. So it's and yet there's an abundance of ideas out there. We're going to have to invent our way out of this a bit. I got one happy example is I got an email yesterday from an old colleague who said, Lee, I've got an idea that I cannot stop thinking about. I need to talk to you about it. And so we're going to Zoom this afternoon to hear about his idea. So Zoom gets no credit for originating the idea, but it's a tool for following up.
Mm-hmm.
Mm-hmm. One of the interesting things, and just 5 minutes ago, my mom came to my door and I said, hold on, not right now, is the idea that being home, you're outside of the walls of people who are, day in, day out, 100% focused on innovation within the healthcare space. And so one of the things that I've found is being able to connect with friends, neighbors, families, and let me tell you, it's physically distanced. I haven't left my little area since March, so it's getting a little ridiculous. But as we look to innovate, we're always looking at ways to innovate to serve people and communities, and being close to that community is so important. One of the things that you just mentioned, Dr. Lynch, which brings me to another question in the queue, which is around solving community health needs. The question specifically is, what role can Fred Hutch play in solving community health needs? And we talked a little bit about from COVID, but are there other opportunities? One of the spinouts that happened a few years back is Tomorrow, a smoking cessation app that is has clinical evidence. So I'm curious about hearing
Yes.
that element.
So I'd say a couple things, Maura, on that one, which is as a comprehensive cancer center, one of the key ways that we're judged as a cancer center is how well do we address the cancer needs of our catchment area of Washington State, essentially, and do we assess and impact community health in terms of prevention and screening and early detection. And so the Hutch has a large commitment to being able to enhance screening services and to meet certain needs of different communities around the state. So we have community health educators, we have patient navigators who get involved with community health to be able to impact cancer. And then probably the biggest way is looking at, again, we have a public health sciences division that works on nutritional issues in cancer. And one of the arguments you made earlier about cancer prevention and how one can look at preventative strategies for cancer. I mean, the difficult things with preventative strategies is how, when Fred said 75% of cancer cancer death could be eradicated, that would be a dramatic change in people's lifestyle and behavior that would require that. And so, making some of the dent on that, I think, is going to be important to try to get some of the way there to be able to do that. But I think that the role we play in educating, people in the community, in working on enhancing screening, and trying to look at what some of the scientifically, what some of the determinants of different cancers and different populations are, I think is really important. I think our viral work is a good example of that. When you look at some of the things we've done with viruses to get a sense of what cancers are going to be more likely in certain environments.
Great. All right, let's take a global look. I think we've got time for maybe 2 questions. Lisa asks, I'm curious where you see the Hutch's role in global oncology and where that field is in terms of priorities or not at the Fred Hutch.
So, Maura, as you may know, we have a facility in Uganda that is a place where we have a Fred Hutch. We have Fred Hutch employees who work in Uganda at the Uganda Cancer Institute, working on treating people with cancer there. In fact, we are doing clinical trials in Uganda. I think one of the things we'd like to probably 2 reasons for being in Uganda. The first is the fact that how you treat cancer in a low resource setting, meaning where they don't have a Seattle Cancer Care Alliance, is really important. Okay, and thinking about how do you come up with treatments that you can do in a place that doesn't have the kind of technology that we have in Seattle is critical. So that's one of the things we're looking at in Uganda, with the hope that that will be able to be disseminated to other parts of the world, and coming up with new treatments that, instead of someone coming in for an intravenous treatment, which again requires an infusion room, can you come up with a cancer treatment that you can just give as a shot instead of a infusion? So it's much less technology that could be involved. So that's one of the reasons that we think it's so important to be there, is to understand that. The second is that Uganda has a slightly different number of cancers. The cancers are a little bit different. They tend to be very virally, many of them are virally based in terms of liver cancers and lymphomas. Uganda is where Dennis Burkitt, the famous oncologist, did some of the work that described Burkitt's lymphoma in that part of Africa. So it does give our people working in viral oncology the ability to have have an impact and think about how cancers may be different in that setting. We also have a facility, a Fred Hutch facility in South Africa, and the South African facility is focused entirely on HIV. It's an HIV-focused facility because, as many of the people on this call know, HIV remains an enormous problem in South Africa and in Africa in general and globally. And this is a place where many of our efforts in terms of HIV vaccines and HIV prevention have been worked on. So I think as a center, we do have a global footprint. I think one of the questions is, do we get involved in South America? Do we get involved more in Asia? Those would be questions that we'll be looking at as time goes on. But we have a footprint in Africa, and it's something we're very proud of. And I think that over the years, the Fred Hutch facility has made a real difference there.
Fantastic. All right, last question, and it's going to be a closing thoughts question because we are unfortunately at our end of time today. I'm going to pose it to both of you, but Dr. Lynch, I'd like for you to take it first. Last question is advice for the innovation community throughout. We are, I don't even know what month we are now, month 8, month 9 of the pandemic, and innovation is needed more than ever. What advice do you have for the community at large?
So the great thing about this, Maura, is that innovators are the last group of people that need to be reminded that there are unique opportunities that happen during times of crisis. And true innovators are the people who step forward during times of crisis and find new ways through problems. And so I think that the time is ripe for innovation. The timeframes that we look at for product development and for change, when you're in a time of change, people will accept change better. I think we're in a time like that, and I think innovators will innovate. And so they'll do it more now than they would in a time when things are stable and stagnant. They're anything but stable and stagnant now. And I think much of the reason that I'm optimistic that we're going to get through this are the remarkable people that we have in the innovative community in the United States, in Seattle, in the Bay Area, and other parts of the country where people really are coming up with very, very interesting ideas. I think there's also one other piece I want to say, which is I'm a medical oncologist, a lung cancer doctor. I'm an optimist at heart. And my wife is a journalist, and she wrote an article for the New York Times last week where she profiled a school district in central Tennessee that had decided to repurpose some of its screening equipment that was using to look for tornadoes, because that part of Tennessee gets a lot of tornadoes. And they had all this safety equipment for tornadoes, and they used a lot of it to be able to enable education for the children in that school system. And there are lots of stories like that all over the country of people who, Americans in different settings, who have found ways to innovate and have found ways to make things work. And we tend as a country sometimes to focus on the negativity and what separates us. But what brings us together are stories of collaboration, stories of innovation, stories that bring together some of the best parts of people and create some of the solutions that are working in many places. And yes, there will be challenges, and we've got a lot ahead of us. But I have confidence that people will rise up and find ways to make a difference, as long as we don't put too many barriers in front of them.
Thank you, Dr. Lynch. Lee, some thoughts before we close out today's event? Advice.
Well, I'm reminded of the observation that the things that are going to change your world are almost never a total surprise. There are things that are out there that you underestimate the impact of. And often that's technology or discoveries or new ways of doing things. But you see it, but you don't appreciate its possible impact. We're in a season of science and technology, and now you can regard this pandemic as an accelerant in some ways. There's lots of fresh thinking going on. So it behooves all of us, entrepreneurs and others, to find the bandwidth to look around, see the new ideas that are percolating, and take some stock of their potential impact. Because I can't predict what it's going to be, but there's going to be new energy and new directions that come out of this season.
Gentlemen, thank you both for your time today. It is always a pleasure to see both of you, and thank you for all of your work as we look to potentially get somewhat back to normal or a new normal very soon. Everyone in the audience, thank you for joining us. A recording of this session will be sent to you tomorrow. And until then, really appreciate your work and time. Have a great day.
Thank you, Mrna.